series, the inaugural session of 2026, with another interesting topic today being dialysis-related complications. Thank you, our guides and conveners, Dr. Vijay Kher, Chairman, Epitome Hospitals, Delhi, and General Varma, Principal Director, Venkateshwar Hospitals, Delhi, for giving us this opportunity to host such a wonderful series. And request you to introduce our faculty for today. Thank you.
Thank you very much, Puneet. And yes, as you rightly said, welcome to all the students and colleagues in the new year and wishing them very happy new year. Today we are having a discussion on complications during dialysis, and we have got the examiner today is Professor Mayuri Trivedi. She is a senior consultant and head at Lokmanya Tilak Hospital and GH Sion also. She is a very avid worker, avid, very excellent nephrologist, and a good teacher. So she will be presenting she will get the case presented through her student, Dr. Naman Jain, and the discussant will be Professor Umesh Khanna. I think we all know he's a very, very senior nephrologist and well looked after nephrologist, excellent teacher, and beautiful clinician, and a wonderful human being and a good friend. He is the founder director of Kidney Associates Mumbai, and he is also the chairman of Mumbai Kidney Foundation. He has series of dialysis centers in Mumbai, and I think we thought that there's no other person,
Recording in
better person
progress.
who can talk about complications during dialysis. And the expert is my own teacher, Professor Vinay Sakhuja, uh, Principal Director at Max Super Speciality Hospital, Mohali. And I'll request Professor Vijay Kher to introduce the session today and take it forward now.
Thank you, General Verma, and good evening, ladies and gentlemen. Welcome for the first session this new year, and I wish all the faculty as well as the audience today a happy new year, and I hope this year is more fruitful and also forgiving. Dialysis and kidney transplantation have been, I think, two remarkable discoveries in the last century. And I think both these modalities of treatment of chronic kidney disease have increased the lifespan of patients of kidney disease. And every treatment, although very remarkable improvement in the quality as well as in the quantity of life, but then there are obviously going to be some complications on long-term dialysis, short-term problems in dialysis. And I don't think there is a better person than Umesh Khanna, who I think he's been one of the first pioneers as far as setting up satellite centers in dialysis in the country. Elsewhere in the world, a lot of dialysis is done in these satellite centers, but in India, I think he was one of the first ones to do this. And so there isn't a better person than him, and he owns many dialysis, large number of dialysis patients whom he has followed for many years. And then, as Dr. Verma said, Mayuri, who I consider very close, I would say that is like my daughter, and I have huge fondness for her work as well as the way she's been carrying herself over the last 5-6 years or so. So I am glad that she's going to be the examiner for this case today. And Vinay, I don't think I have to say anything about. Vinay is always such an inspiration at any time. So I would say, Naman, you can go and start, and I think we'll have Mayuri to do the examination for about 45 minutes, and then we will give Dr. Umesh Khanna at least about half an hour to talk to us about the various complications and the way he would want to say what have been the great effects of dialysis over the years.
Uh,
Naman, all yours.
Thank you, sir. Very good evening to everyone, all and to all the seniors, and thank you for giving me the opportunity to present the case. Myself, Dr. Naman Jain from LTMMC. I'm going to present my case. My patient is a KD, 57-year-old female, resident of Sion, Kolivada, Mumbai, as educated till 4th standard and homemaker by occupation, and right-handed, presented with chief complaint of tingling and numbness in the left hand during hemodialysis since last 2 years, pain in left hand during hemodialysis since last 6 months, and a ulcer over left index finger since last 4 months. According to my patient, she is known case of hypertension since last 30 years and known case of type 2 diabetes mellitus since last 15 years and CKD since last 5 years and is on maintenance hemodialysis since last 2 years. Patient was apparently alright 2 years back when she got an AV fistula created in her left arm over the cubital fossa, and hemodialysis was started via AV fistula after 2 months of creation. Patient started having tingling and numbness in the left forearm and fingers, which was associated with pin-pricking sensation, coldness of hand, which used to relieve with soaking of arm in the cold water. No such complaints in the right hand. There was no paleness or discoloration of the hands or nail initially. No difficulty in movements of finger. No loss of sweating over the hands. Her symptoms aggravated since last 6 months when she started having pain in left forearm, palm during dialysis, which has now increased in the severity, and currently she is having a pain at rest even without dialysis. This was also associated with difficulty in movement of the wrist and fingers, blackish discoloration of fingers of the hand, loss of sweating, brittle brownish color nails, thinning of the palm as compared to right hand. She also had a minor cut over the left index finger, which 4 months ago, which gradually increased and now has become a non-healing ulcer. Her pain has now become intolerable during dialysis so much that the SD has to be discontinued in the middle of the dialysis during the last few sessions. Patient is not do not have a such complaint in the right hand. Patient had a fracture in the left foot 3 months ago due to trauma, which was surgically fixed with a plate insertion, but surgical wound has not healed yet. The patient does not have complaint of pain during walking, tingling and numbness in the leg, no loss of sensation to hot and cold in the feet, no discoloration or loss of sweating in the or thinning of the legs. Patient is currently taking hemodialysis thrice per week via left proximal AV fistula. Her dry weight is 65 kg. Intradialytic weight gain is 2 to 3 kg and has a residual urine output of less than 100 ml per day. Patient had a raised blood pressure during hemodialysis. No interdialytic hypotension, no difficulty in cannulation of the vein, no prolonged bleeding time post hemodialysis, no issue of the pressure alarms or blood flow issue during the hemodialysis. Past medical history: patient is hypertensive since last 30 years, which she was non-compliant to treatment and her blood pressures were uncontrolled. She is currently taking nicardipine once daily and carvedilol, and does not recall or missed and have missed the doses of the medication before the hemodialysis. And patient was also diagnosed with type 2 diabetes mellitus, for which she was taking OHS earlier and was compliant to medication, but her blood sugars remained uncontrolled and therefore was switched to insulin 4 years ago. But as she started having episodes of hypoglycemia, she was again switched back to OHS, and her blood sugars are currently controlled. She was diagnosed with diabetic retinopathy when she had a complaints of blurring of vision 2 years ago, for which she was advised intervention but were not followed. No history of laser or VEGF injection, anti-VEGF injection. No follow up. She was detected with the bilateral eye cataracts. A patient was diagnosed with CKD in 2022 when she used to have bilateral pedal edema, dyspnea on exertion, and decreased urine output, and her serum creatinine and lab values are not recalled. She was advised for hemodialysis during that time, but she was not willing. She also had anemia, for which she received 1 unit blood transfusion. She was prescribed on oral medication, details of which are not recalled, but symptoms kept worsening and has to be admitted because of breathlessness, requiring an IV support and ICU admission 5 months later. This time she was initiated on hemodialysis, access being right femoral HD catheter, 3 consecutive sessions of HD were given, after which her symptoms improved, and her access was later changed to left IJV catheter, and right femoral catheter was removed. Right IJV catheter was not attempted this time. Later, a right IJV tunneled cuff catheter was inserted before discharging the patient. A left proximal AV fistula was created 3 months later, not attempted over forearm, citing the poor veins development. Fistula matured around 1.5 months later, and hemodialysis was started via AV fistula with no issue in difficulty in cannulation or blood flow issue during the hemodialysis. After few sessions, right IJV tunneled cuff catheter was removed. Patient did not receive any blood transfusion on hemodialysis and has not been vaccinated. Obstetric history. Patient has LMP 9 years ago, P3L3. First child was a female with a birth weight of 4.5 kg, who is currently 28-year-old, and required LSCS during that pregnancy in view of large baby head size at 9-month ANC. This patient was detected with hypertension for the first time during the 7th month of the pregnancy. No edema, or do not recall having proteinuria or antihypertensive were continued since then. Second child was 20-year-old male with a birth weight of 2.5 kg, had a full-term normal vaginal delivery. Her blood pressures were controlled during this pregnancy and did not recall having any proteinuria. Third child is a 15-year-old female with a birth weight of 3.5 kg and was a full-term normal vaginal delivery with no ANC complication. And patient underwent a tubal ligation 15 years ago after this delivery. Family history: husband is a 65-year-old non-hypertensive, non-diabetic with no other comorbidities. Two siblings, one brother and sister with no comorbs. Case summary: 57-year-old female, known case of hypertension since 30 years, detected during her first pregnancy, non-compliant to treatment, uncontrolled blood pressures during hemodialysis, with type 2 diabetes since 15 years, earlier uncontrolled with diabetic retinopathy and bilateral eye cataract. CKD since 3 years, initiated hemodialysis in view of fluid overload with previous axis being right femoral vein, left IJV temporary catheter, and right IJV tunneled cuff catheter. Currently having left proximal AV fistula with history of 1 unit blood transfusion 3 years ago. Currently symptomatic since 2 years. Initially presented as tingling and numbness over the left hand during hemodialysis. Now severe pain during the hemodialysis, requiring hemodialysis termination with tropic change, muscle wasting of the left hand, non-healing ulcer over the left index finger, and no symptoms in the right upper limb or bilateral lower limbs. Currently, patient is taking thrice per week hemodialysis with dry weight of 65 kg and intradialytic weight gain of 2 to 3 kg and residual urine output of less than 100 ml. Has intradialytic hypertension without any other intradialytic complication. My impression would be comorbidities of diabetic with diabetic retinopathy and hypertension, CKD stage 5D, native kidney disease, likely diabetic kidney disease with intradialytic hypertension, and AV Steele syndrome, or could be distal arterial stenosis or peripheral vascular disease. Should I move on to examination?
Should we finish the examination or take the questions in between?
No, I think you can do it the way you want it. If you have any specific questions, you can do it, or you can do it after the examination.
Yes, sir.
Whichever.
Yes, sir. Naman, finish the examination.
General examination. Patient sitting comfortably on the bed, well oriented to time, place, and person, with blood pressure of 140 by 80 in right upper limb in sitting position, afebrile, respiratory rate of 16 per minute, abdominothoracic, with pylorus present, no ictus, cyanosis, clubbing, or pedal edema, pulse rate of 76 per minute, regular, normal character and volume, no radiofemoral delay. On pulse examination, the left radial pulse were not palpable and bilateral ulnar pulse were feeble, less tolerable, normal. There is no swelling of the face, no periorbital edema, though no dilated veins over chest or neck. Nails of the left hand are brittle, brownish in color. Right hand is normal. Palm, left hand is colder, paler and thinner as compared to the right palm. Wasting of thinner eminence is present in the left hand. a superficial ulcer of around 1 centimeter present over the left index finger, non-healing surgical wound present over the dorsum of the left feet, examination of AV fistula. On inspection, the fistula was present over the left cubital fossa with a transfer scar present over the cubital fossa and a straight venous segment of 6 to 7 centimeter visible over the arm with multiple cannulation mark, no scab mark, no redness, swelling, pulsation or around the AV fistula or the venous segment, no visible venous collaterals over the arm, neck or chest, no other scar mark on the forearm or the or near the wrist. On palpation, soft pulse was present, no warmth or tenderness around the AV fistula. A continuous thrill was present over the AV fistula, which was felt over the venous segment also. On augmentation test, a continuous blue on auscultation, a continuous blue was present over the AV fistula and venous segment in same with same intensity in systole and diastole. On pulse augmentation test, the pulse became stronger on the outflow compression. The pulse increased over the AV fistula and thrill disappeared. With no collaterals were seen. On arm raising test, AV fistula venous segment collapsed during the rising the hand. On Allen's test, the right hand had a radial time was for the filling was less than 2 seconds, and earlier took 5 seconds. And left hand radial pulse was not palpable, and as the hand was already pale, could not be elicited. On CNS examination, sensory and reflex examination was normal. There was no postural hypertension, and gait was of the patient was normal. On checking the muscle bulk, there was significant difference. Left hand was thinner as compared to right hand, and rest motor examination were normal. And respiratory, CVS, and per abdomen examination are also normal. So case summary: a 57-year-old female, known case of hypertension since last 30 years, detected during her first pregnancy, non-compliant to treatment, and uncontrolled blood pressure during hemodialysis with type 2 diabetes since 15 years, earlier uncontrolled with diabetic retinopathy and bilateral eye cataract, CKD since 3 years, initiated hemodialysis in view of fluid overload, with previous access being right femoral vein and left IJV temporary catheter and right IJV tunneled cuff catheter, currently having left proximal AV fistula, with history of 1 unit blood transfusion 3 years ago, currently symptomatic since 2 years, initially had symptoms of tingling and numbness over the left hand during hemodialysis, now severe pain during hemodialysis requiring termination, with topical change, muscle wasting and non-healing ulcer over the left index finger. No symptoms in the right upper limb and bilateral lower limbs. Currently taking thrice per week hemodialysis with dry weight of 65 kg and intradialytic weight gain of 2.5 to 3 kg and residual urine output less than 100 ml. And has intradialytic hypertension without other complications. On examination, pallor was present with topical change and muscle wasting in left hand with feeble pulses. Left hand was cold and pale as compared to right hand. Rest of the AV fistula examination were within normal limit. So final impression would be type 2 diabetes with diabetic retinopathy with hypertension, CKD stage 5D, native kidney disease, likely diabetic kidney disease with intradialytic hypertension with anemia, with the patient likely having AV fistula Steele syndrome or distal artery stenosis, or could be peripheral vascular disease.
Right, Naman. So, when you come to your impression, you've said that the patient probably has an AV fistula Steele syndrome. Are you still doubtful that he has a AV fistula Steele syndrome?
Patient has AV fistula Steele syndrome, but could have been worsened with a coexisting peripheral vascular disease also.
Yeah, so he has a dialysis access related Steele syndrome that's called as DASS. The etiology may be any of that you said. So now tell me, what are the normal hemodynamic changes that happen when you create an AV fistula?
Ma'am, after creating the AV fistula, the blood flow across the segment gradually increase.
So what is the normal blood flow, that an average blood flow across the
radial vessels? It is around 40 to 50 ml per minute, and in the
less, it's around 80 to 100 ml is what normally it would be, which would increase to
would gradually increase to more than 600 ml per minute after maturation of the fistula.
Okay. So essentially, and what else happens? The physical changes that happen.
Yes,
You
ma'am.
have
The venous
what happens to the inflow artery? What happens to the outflow vein?
venous segment gradually undergo the hypertrophy, and the segment became dilated and more prominent, and the arterial segment, uh, the blood flow through the arterial segment also increases.
Also increases, right? So, is there any, in your case, is there any other feature that kind of hints to the fact that this patient may have a peripheral vascular disease?
Yes, ma'am. The firstly, ma'am, patient is diabetic, which was uncontrolled, and also the
The
patient is
diabetes itself is a risk for the peripheral
yes, ma'am.
arterial disease, yes.
Yes, ma'am. Also, patient is having a non-healing ulcer in the left foot, and also on the examination, the ulnar pulse of the right hand was also palpable, and on Allen stat it was also borderline. It took around 5 seconds for the pallor to disappear. So, which
So that
can
was on
which
the good hand,
yes, ma'am, on the right hand, which
on the
suggests
right.
a coexisting peripheral vascular disease.
Would this thing a peripheral vascular disease? I agree. So, but can you tell me what are the causes of the DAS, of the dialysis access steal syndrome?
Ma'am, firstly, in the blood flow through across the AV fistula, which is if it is more than 2000 ml per minute, which will cross the ischemia in the distal segment, and if it is if there is a stenosis or peripheral vascular disease in the distal segments in the radial vessel, will also contribute to the ischemia.
No, so I think it would be easier for you to understand the pathophysiology. Of course, even the students is that there are three parts to a dialysis access steal syndrome. One is the inadequate inflow. So the artery inflow is an issue. So you're having an inadequate inflow, which could be due to a central venous stenosis anywhere up the line. So you can have a subclavian, whatever. And remember one thing, that dialysis access steal syndrome is more common in the brachial fistulas as compared to the distal fistulas. So if there's any issue in your inflow, this with a stenosis anywhere down the line, in the inflow segment, you're going to, which can be anywhere from the subclavian to the brachial. So that's one. Two is that you have as you said, the peripheral arterial diseases or diabetes or any systemic disease like a systemic sclerosis or whatever, which is going to cause an increased distal artery resistance.
Yes,
So
ma'am.
during diastole, there is a reverse in flow and the distal segment is going to get ischemic. And the
Yes, ma'am.
most uncommon would be when there is a low venous outflow. So when you have the arterial and venous segment having a mismatch where there's a high outflow, this thing for whatever reason, in that case, again, that would be the third cause why a patient would require a would acquire this thing. So, do you know what the stages of dialysis access steal syndrome are?
I mean, dialysis access
So,
steal
classically,
syndrome.
your patient has gone from one stage to another.
Ma'am, in mild, patient has
So, how
symptoms
many
of.
stages are there?
Ma'am, patient can have mild, moderate, of severe symptoms. The in mild, patient can have just tingling and paresthesia, which can be managed conservatively, and in moderate symptoms, we would have to take intervention, and where the patient will have pain only during the hemodialysis, and in severe, the patient will, if the patient started having a pain even at the rest, will suggest the severe system will require the AV fistula takedown.
Okay. So takedown or whatever would be the surgical
Yes,
interventions
ma'am.
that you would require. So your patient has very classically, she had no symptoms initially. Then she
Yes, ma'am.
started having symptoms only on, during the dialysis where she started having the pain. Then she started having the symptoms typically when she was at rest. And last, she started having the thinning and the non-healing ulcers, the trophic
Yes,
changes
ma'am.
that she had. And definitely your history does point to the fact that she has a peripheral arterial disease somewhere down the line and diabetes by itself. So what are the risk factors for a patient to develop a dialysis access steal syndrome?
Ma'am,
So
first of all,
you've enlisted a few. You've said the
yes,
history
ma'am.
of peripheral artery.
Elderly
You've said
patient.
diabetes itself. What else?
Yes, ma'am. Elderly patient. Uh, Elderly, ma'am. Female would have a higher risk than males, and coexisting. If the native kidney was vasculitis, will have a higher risk. Systemic sclerosis would have.
So any systemic vasculitis which would affect the vasculature would affect this. Yes.
This one.
Naman, smoking?
Yes, sir.
Smoking, yeah, very important.
Yeah, I thought that would be high on the list,
High
and
on the-
vasculitis and
No, but
other things. I thought
why did
that
you
would
say
be.
in ladies it is more common?
Sir, estrogen would be a factor.
Estrogen causes vasodilation.
Dilatation, not.
Yeah.
My only question
Maybe
is,
the vessel diameters and all may be smaller, probably the
Yeah.
size of the musculature and all those, that might be, so that but I'm not sure. I am not sure that it is more common in females. But you
so
may be well
literature-
read. You may
Yeah,
be well read, so I don't know.
So the literature does say that it's seen more commonly in women as compared to men, and one of the major contributing factors is because their vasculature is a little more delicate as compared to males.
Yes. Naman, what
Yes.
if you were to make an AV fistula? So
Yes, sir.
what are the things you would do to prevent this kind of a complication? How would you sort of
Assess
look at, and what would be the things that you would do to that this kind of complication doesn't occur?
Yes,
Isn't it? I think this is something which shouldn't occur.
Yes, sir.
Unfortunately, it has happened, but ordinarily with a procedure which is likely life-saving otherwise for the patient,
Yes, sir.
one would try to see that this doesn't occur. So what
Yes,
are the things that you would do to see that this doesn't occur?
Sir, firstly, a thorough clinical examination.
and one
before-
more question also, Naman.
Yes, sir.
Why did you allow it to occur to this extent?
Yeah.
Why didn't you interfere?
That's the second question which I had, but I thought, let me first hear what it is.
You
What
said
is it
rightly there
that
are
you would
4 stages.
Yes, sir.
She has gradually gone from stage 1 to 4.
Yes, sir.
She has got weakness. She has got
sir.
the loss of muscle mass.
Yes, sir.
Eminence is gone. She has developed trophic ulcers. Isn't it too late to intervene now?
Yes, sir. It is, sir, too late. So, but this patient was referred to us at a very late stage. She is not our primary patient. So we managed when she came to us.
Okay. What will you do to prevent?
Sir,
What are the things that you would do?
a thorough clinical examination, including, sir, Allen's test must be performed before to check the vessel patency. And secondly, sir, we would have to do a ultrasonography, Doppler study to check the vessel size, and also after giving the torsion, if the vessels are compliant or not. And thirdly, sir, if the patient is smoker, we will have to strictly advise them to stop smoking. That will decrease the complication. And sir, uh, history of previous access. If the patient has a history of a access insertion on the same side, with will increase the risk of complication in the later stage. And if we have if the patient is in our follow-up, we will try to preserve that side.
No, you have this patient, so I don't know. You tell me, what would you have done to prevent this? So this is the patient you have.
Yes, sir.
You know the history, so it's not that if you have this and if you have this. So you have a patient. So what would you have done? One is, I agree, you did a good clinical examination. You did a
Yes, sir.
Doppler of the arterial and the venous system of the both
Yes, sir.
arms. Okay.
Before creation of fistula.
Yeah, before creation of fistula. Okay, what else? Because that would have also told you about the peripheral vascular disease, hopefully, at least given you a suspicion that this
Yes.
patient may have a peripheral vascular disease as such. Okay, what else?
Sir, while after creation of the AV fistula,
No, before creation of AV fistula in this patient.
These patients are strict diabetic control and
Good.
in the long term.
Good. That's okay. That's okay.
No.
You heard Mayuri telling you that any obstructions anywhere else in the
Yes,
system. So would you have wanted to look at it? she has had cannulation on
Yes,
both
sir.
sides in the internal jugulas,
Yes,
isn't
sir.
it? So
Yes,
would
sir.
you look at central venous stenosis or something,
Mm,
or
Sir,
no?
if the patient is a high risk, I would like to look at it also.
So what do you mean high risk? I don't know your patient. This patient,
Yes, sir.
you would have
Patient.
wanted to do a central venous studies or the vascular studies to look at the central venous stenosis or narrowing or any other complications or not. Somebody who has already had history of
Yes, sir. If a
central
patient has
venous
a history of
catheterizations.
multiple axis insertion, we would have to look for CVO.
Yeah, so I think that those are uh, essential things, especially in a patient who's had already some kind of central venous catheterization, so that you would. And I think these are becoming more and more problematic now. And I keep on wondering whether uh, central venous catheterizations, which remain and fistulas are not made very early in our patients, and we are getting into more and more complications of vascular access these days. And
Yes,
it
sir.
is going to
Yeah.
grow because more number of patients are now remaining alive on dialysis for longer period of time, and therefore this would be a vascular access would be, it continues to be an Achilles heel, but it would remain a bigger and bigger issue,
Yes, sir.
especially with central venous catheterization so commonly being the initiation of dialysis in our patients.
Yeah,
Yes.
just one point, Dr. Kher. There's no edema of the upper limbs on either side, neither on the side of the fistula or on the opposite side. So that would be, and no collaterals that have been described in this patient. So that would be a point against central venous stenosis. Although I agree that this is becoming a very big problem now in our patients. But in this patient, I don't think we have any evidence for that.
Yeah. I agree.
Yeah.
I agree. On examination, you don't have. But what happens before you make a fistula? When you make a fistula, then the flow increases all of a sudden into
Yes,
the
yes.
systems, and
In
then the
yes,
edema and all the
yes. In
channels open
fact,
up, and
it may
that's what.
become
Therefore,
evident only.
yes,
It may become evident only after you make the
after you
fistula.
have made the fistula, and
Yeah,
that's the
yeah.
reason why you might have to suspect in people who have, you may want to do it before you want to make an
Yes,
AV
yes,
fistula.
yes.
Yes.
So
Yeah.
I think even if this patient had presented to us 1 year or 1.5 years ago with just those tingling or whatever, at that point of time, we would have definitely looked for a CVO in this patient.
Yes, I would agree with that. But I'm saying that one should try to prevent these kind of complications, because once they occur, then obviously you need now a drastic kind of a step to take care of it. Okay.
So we had to take down
Okay.
the
Okay.
fistula here, sir.
Yeah. Okay. You go ahead.
Yes. So right, Naman. So when a patient on CKD who's on long-term dialysis comes to you,
Yes, ma'am.
what are the points of examination of an AV fistula? What would you normally carry out? Can you enlist those for us?
Yes, ma'am. For the AV fistula examination, ma'am, firstly, on the inspection, we will look at the site of the AV fistula and color of the skin over the AV fistula, any pus discharge or any other discharge or bleeding over the AV fistula site, and is, uh, skin characteristic over the AV fistula, if it is tense or dilated, any visible pulsation over the AV fistula, and on the distal to the AV fistula, we will look for any other scar or presence of the attempted AV fistula creation on the distal side, uh, any with ulceration or topical changes like nail changes, loss of hairs over the palm or arm, distal to the AV fistula. On
Even the skin changes, right? You will have
Yes,
this
ma'am.
shining skin, shining stretched skin,
Yes, ma'am.
or any
If,
aneurysms, any swellings.
yes, ma'am.
Hmm.
Cannulation mark and the venous segment. We will look for the length of the venous segment and cannulation marks over the venous segment, and distal and on the proximal aspect we will look for any visible collaterals over the arm, neck, chest, or even the face, and any swelling over these area also. On palpation, we will check the thrill over the AV fistula, any pain, tenderness over the AV fistula, and
Are
the
there any
venous segment.
specific tests that you do in palpation?
Yes, ma'am. We do one
What is the hand raising test or the arm raising
hand
test?
raise. Ma'am, arm raising test is done to see the if there is any uh, blockage proximally. So we ask the patient to lift the arm, and on lifting the arm, the venous segment should collapse ideally. Uh, but failure to collapse of the venous segment would suggest a severe stenosis or distal stenosis.
And the pulse occlusion test?
On the pulse augmentation test, we occlude the distal segment via the palm, and notice the change in the characteristic of the pulsation of the AV fistula. The normal thrill should disappear, and the normally the on auscultation the fistula will become hyperpulsatile, and
So this is for a normal patient.
yes, ma'am. Normally, but if there are collaterals, the thrill won't disappear, and we will see the visible collaterals on compression of the distal vein.
Right. So signifying that there is a stenosis somewhere.
Yes,
Now you
ma'am.
said that there you have to look for pus and you have to look for some kind of an infection or whatever. So this is for the students, that when you have a dialysis case or when you have a vascular access case, you would definitely have questions related to the dialysis which be asked. In case you don't have it in your 4 cases, you are definitely going to be asked dialysis in your dialysis rounds or your short cases or your bedside cases, as it is called in DNP. Okay, so dialysis is something that you cannot avoid in your exam. Somewhere you are going to get. So we'll move on to some dialysis related questions. So you said about this pus and this thing. So these are, so apart from your CRBSIs, what are the other causes of fever that a patient can have who's on dialysis?
Ma'am, patient might present with fever with other causes like tropical infections like malaria, dengue.
Any tropical that any patient can. So specifically, can you think of something which is with relation to diabetes and vascular dialysis and vascular access?
Uh, Vascular access, ma'am. CRBSI.
CRBSI, definitely. You have to be a little, this in your infective endocarditis, your infections
Yes, ma'am.
of the AV fistula itself. You can have vegetations there.
Yes, ma'am.
Plus any infection. So we are going to have Dr. Umesh Khanna discussing these, the non-CRBSI infections in these patients. Now, you said that this patient was not vaccinated. So what are the normal vaccines that you recommend for a ESRD patient?
And normally we would recommend to vaccinate for hepatitis B and influenza and pneumococcal, and
What kind of
also
pneumococcal vaccines do you ask for?
PCV 13 and PCV 23 are recommended, which are given 4 weeks apart, 8
4?
weeks apart.
8 weeks. Huh.
You now have
Nowadays it is gone.
Prevnar 20 available.
Now it is Prevnar 20, only one injection.
Only one injection. You don't need to give 2.
Yes, sir.
That is gone now.
Yes.
Go ahead.
Right. Yeah. So, any other vaccinations that you think these patients should take?
Ma'am, COVID vaccination is recommended, and also herpes zoster is also suggested, can be given.
Are you recommending COVID vaccine nowadays? I don't think it's available even. I'd like to be informed if it is really available. I'm not advising it to my patients.
Yeah, I don't think it's available
Not
easily
yet.
now.
What you said, initial 3, yes.
Yeah, that is fine.
That is B, influenza, pneumococcal, and 3 doses. 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 3 d
Hepatitis B.
Some people might think in terms of herpes zoster also.
Yeah, maybe.
Shingles.
Correct. Shingrix if
That is-
diabetic or elderly, 45, 50 plus.
Yeah, the only problem is the cost.
Yes.
It is.
So, Naman, COVID is not a recommendation anymore. I don't think it's even available, if I'm not mistaken.
Yeah.
COVID vaccines are not available. Okay. What is the dosing schedule that you follow for hepatitis B?
And hepatitis B vaccine usually given the double the dose of normal.
Why?
Is normally because the patient is already have a low immunogenicity and therefore require a higher dose. So normally we give 20 unit in a CKD patient. We advise for 40.
20 micrograms, not units.
Yeah. Micrograms.
Yes, sorry, sir. CKD we recommend for 40 microgram, which is given as 0, 1, and third month and fifth month.
2 and 6.
0, 1, 2,
6.
4 doses.
What
For
is
the kind of seroconversion with this vaccination in dialysis patients?
If a dialysis patient has come, and as Dr. Kher is asking you, you have given these 4 doses.
He's not been vaccinated before, now
sir.
you are vaccinating. What is the seroconversion with vaccine in an end-stage kidney disease with these dosages?
Yes, sir. We will have to recheck for the antigenic titer, antibody titer after 2 months.
Specific question.
That's the question. What is the percentage of people who will have adequate antibody titers? And what would be considered as an adequate antibody titer?
Yeah.
So more than 10 international unit per ml of the antibody titer will be considered.
Yeah, but in Indian conditions,
will not last long.
Yes, 10 is not going to last long at all. And I think ordinarily we will require something like 100.
100,
an
yes.
antibody titer of more than 100. Yeah, more than 100.
The seroconversion rate will not be
50%. Less than 50%.
50%.
Less than 50%.
If you are giving a dialysis patient.
Yeah.
Previously, you used to give adjuvants.
Yeah. What are the adjuvants which were used? Do you know, Naman, any adjuvants which were used previously?
Sorry, sir.
Or which have been used, you may have read about in the literature as such.
Sorry, sir, I can't recall.
No, you don't know. GM-CSF was used. Yes, was used, and in fact, we had published a paper long time back.
Yes.
And what would be the difference in vaccinating, say, a transplant patient 6 months after the transplantation? Would they be better off or would they be worse off than dialysis patients?
So
both are immunosuppressed. Both are immunosuppressed. Where is immunosuppression more, and what may be a specific kind of an immunosuppression which may be present in CKD? In fact, you may not be knowing it, but I can tell you that, in fact, what happened is that there were 7 patients which were seronegative or didn't seroconvert. So we transplanted these patients, and 6 months after the transplantation, we revaccinated them. And 5 of the 6 patients, although on maintenance immunosuppression, all 5 of them seroconverted after the transplantation. So suggesting that, in fact, this was a PhD thesis for one of our students. And then he also looked at specific sort of defects in T cells, CD3 T cells, which is specifically related to the vaccine immunogenicity. And these defects are present far more in patients of chronic kidney disease. And therefore, seroconversion doesn't occur. And what would be the method if you were to vaccinate them? When would you vaccinate these patients?
Sir, in CKD patients, we would advise, they are advised to vaccinate it when they reach stage 3.
And you see them first. So try to vaccinate your CKD patients as soon as you see them.
Yes, sir.
Because in early stages, the seroconversion is almost 80% and above.
Yes, sir.
Yeah. Okay.
Okay, so extension of the same discussion, Naman, should your patient not seroconvert, then what is the next step?
Ma'am, we will.
So you've given 4 doses, you've checked, it is less than 100. Now what do you do?
Ma'am, we will repeat on the repeat titer. If the patient have no seroconverted, we will give the repeat a complete schedule of the hepatitis B, and then recheck after the 2 months. And if the patient is still not seroconverted, we will leave it there, means considering the patient as non-immunogenic. And we can try the newer hepatitis B vaccine, which is again Hep CRY antigen, which is given as two doses 1 month apart, which for which patient may respond if the patient was not responsive to generic B.
Okay, what about intradermal
Yeah, that is
vaccine
another method to
of
increase the
increasing?
immunity.
Yes, and
Repeated
this was
intradermal injections.
yeah, this was shown by CMC Vellore in one of their papers that intradermal vaccines probably provide more immunogenicity, and therefore seroconversion rates are higher. And those who don't seroconvert, if you give them intradermal dosages, then you probably would see greater seroconversion.
Naman, now the relevant point now, how are you going to manage this patient? What will be your approach?
Sir, for this particular patient, since the patient is having severe symptoms like pain at rest and including a non-healing ulcer, best would be to AV fistula takedown of this patient and create a new access in the right arm. But for that also we will have to rule out any peripheral vascular disease in the right arm also. And for if we want to salvage this fistula, we can try drill procedure, which is distal ligation and distal devascularization and intimal ligation of the AV fistula to improve the blood flow in the peripheral artery, or proximalization of axis can also be done to increase the blood flow across the peripheral artery.
What have you done for that?
Sir,
In this
for
patient?
this particular patient, we have done the takedown of the AV fistula and
What have you done? Say again.
Takedown of the AV
Close
fistula
the
has been
Close
done.
the fistula.
close the fistula.
Yes, sir. And a right side tunnel cuff catheter had been inserted for this patient to continue hemodialysis. At the same time, we have advised for the evaluation of the right arm and creation of the new AV fistula.
Mhm. Okay.
And what has happened to the left hand now? Is there an improvement and overall in this patient's symptoms?
Sir, after takedown, the pain at the rest has stopped, and symptoms of tingling and paresthesia are also improved to some extent, but topical changes are still present.
Okay.
Because the recovery generally, whatever patients we have seen, is not full.
Yeah,
Yes,
yeah.
sir.
The pain and all persists to quite an extent, but there is certainly relief. Certainly relief is there. Yeah.
So she had almost developed kind of fixed contractures on two fingers.
Yeah, yeah,
The
Yeah.
mobility was very, all that has not come back, sir. But the trophic changes are also still there. But there's a definite improvement in the pain. The
Pain.
temperature has also improved to quite an extent.
Yeah. I
So I think we are. It's almost nearing an hour, sir. You said 45 minutes.
yeah,
right,
yeah,
right.
yeah, yeah.
Any comment you like to give, Dr. Mayuri, before we go to Dr. Umesh Khanna?
Sir, as I already told this for the students, that dialysis is something that you can't miss in an exam. It will come somewhere. Either it will come as a vascular access case or it will come as a complication in dialysis case. And definitely it's coming on the bedside or the ward rounds, as we call it, irrespective of whether it's DM or DNB. So, make sure. And as Dr. Vijay Kher sir always says that, dialysis is your bread and butter. And you
Yeah.
better be, I know it's not very interesting and it tends to be a little difficult, because there's a lot of physics involved in it too. But I don't think you have a choice. The fact that you have chosen nephrology as a profession, you have no escape from dialysis.
No, I think this is bread and butter for nephrology.
Yes.
Exam is one day you might pass the exam even without being asked anything about the AV fistula, but this is going to be your day in and day out practice. And I think everybody should start looking at dialysis patients, go and make rounds in the dialysis unit. I think one should spend as a nephrologist, because you earn your money, predominant money from dialysis. So it's important that, and I think ethical also, that you should go and see your patients and look at their problems and how to solve these problems. And that's how you will learn it. Actually, you'll not learn just by one examination or one case study or something, but day to day, looking at the problems, and then only you will sort them out. So I feel
I'd like
strongly
to,
that, I'm sure Vinay
sorry.
will agree with this.
Yeah, I'd like to emphasize that nowadays in corporate hospitals particularly, because that is what I'm seeing, that the entire dialysis procedure is looked after by nurses and technicians. And there is often no doctor at that location, no full-time doctor. The doctors may be called only if there is a complication. And therefore, the students nowadays are not getting the required training and experience in that area. This may be different in big government hospitals like PGI, but in the corporate sector, this is what is happening. So one has to make a special effort to make sure that the residents are fully trained in this area.
And I think this is also one of the reasons, because DNB is now in most of these corporate hospitals. And I think
Yes.
since nephrologists who are in charge of the training are not putting an effort to see that these students get adequate training, their interest in dialysis also is very, very minimal. And in their practice also, then they don't go and see the dialysis patients. So I think it's not something that's good for nephrology. And I feel it's extremely important for residents to go and spend time in dialysis. When their dialysis posting is there, they're usually called to do some other jobs as well. And I feel that's not right, and they should reject other calls and all that. Spend most of the time when they are on dialysis duty in the dialysis units.
Yeah, that's very important.
Naman, before we move to that, who was the father of dialysis? Who is called father of dialysis?
Sorry, sir, I can't recall the name.
From Dutch, from Holland.
चलो अब तो हिंट भी दे दिया बड़ा.
Sorry, sir.
William Kolff.
William Kolff.
Willem Kolff.
Yeah.
Who later on moved to Seattle, but he was from Dutch. Anyway.
Yes, sir.
And who first started the dialysis? Who did the first human dialysis? That was Sion from Germany.
Yeah.
Did the first dialysis in human beings. So you must know the history at least when you are appearing in the exam.
Yes, sir.
Yeah. I think, Kher sir, we can move to the...
Yeah. I think we should now...
Yeah.
We have kept Dr. Umesh Khanna waiting for a long time.
No, I'm fine. I'm listening to the gems of wisdom which you all are giving it to students. Yes.
Chaliye. Come. Yes. I hope you are in the hotel now.
Yes.
That's good.
Very much.
I think we will request Professor Umesh Khanna now to give his personal experience. That is more important than what he has to convey about the dialysis and the usual problems or whatever he feels. We have not requested him for a specific topic. We felt that whatever he feels is appropriate for students to know about dialysis, he will be addressing those issues. Professor Umesh Khanna. Mike.
नहीं अभी
yes
इनकी स्लाइडें भी नहीं आई.
Yeah. Just trying to share my slides. Of course, fortunately, I've shared the slides with Steadfast also. Technical issues are always there.
What we rightly, Dr. Kher was mentioning, if you tell a student to start a dialysis machine, I wonder if anybody will be able to start the dialysis machine today.
No, I don't think so.
That is
I
unfortunate.
find it extremely difficult for students. I don't think, but I tried to make it mandatory for students to in the
Yes.
dialysis units to maybe do 2 or 3 patients starting dialysis,
Yeah.
closing dialysis, and then even in between learning about the alarms and all those things. Because I don't think these days people
Yes.
learn about the. अगर उमेश ये नहीं होता तो then we can ask
I
the
think the
Zoom.
slides are already there with.
Yeah, then we can
I'm
ask.
finding it.
Yes, sir. We can ask our team to do that, sir.
Yeah.
Sure.
Then let's do that. Let's do that.
It has come now.
Yeah.
Yeah. Here you are. You have the slides. You can make it full screen.
1 second. Go back to Zoom.
Yeah, it's okay.
One
Good.
second.
Yes.
But I am not seeing my slides. Maybe I'll have to
stop share करें.
Yeah, I'll stop share and share again. Again. Right. So, am I audible?
Yeah,
Yeah.
you are audible.
And
You
the
are
slides
audible,
are
but
seen.
try to move your slide. Let's see whether it moves.
No.
Yeah, it's moving. Okay, good.
Am I moving it or?
Yeah. Did you move? You didn't move it? Yes. I think you moved it and then only.
No.
We were in the next slide. Yes.
No, there is again, I think somebody else is doing it.
Yes, sir. We from Steadfast are doing it.
Okay,
Okay.
so then you.
Tell me,
So you
whenever
can-
you tell me, I will change the slide.
Okay, let's do the
Yeah.
slide
You can then stop share
Sure.
your own slides.
I have stopped, I think.
Okay. Steadfast, maybe make it full screen.
Is there an issue?
There's the play.
Yeah, no, it's okay.
Continue to share. Fine. So thanks, Dr. P Varma, Vijay, and Dr. Sakhuja for this wonderful initiative, which actually I'm sure the students must be loving it. And it's not only a learning for the students, but all those who attend this meeting. I was asked, next slide, please. I was asked to, we had a alumni meet at KM just about a week, 10 days back, and I was asked to talk on the 10 vexatious issues I faced in my dialysis practice. And a lot of them have been covered in this exam of Naman. And a few points which are added, especially the last one, that nephrologists not been able to give enough time in HD units. So these 10 vexatious issues, I thought I'll just enumerate first and then pick up one of the topics. So the first problem which I faced is convincing for early or timely AV fistula, or even for a timely follow-up. Like in this patient, she refused and eventually crash landed, which happens in a lot of patients. So the dialysis is not started on time and therefore they become malnourished and hence again prone to develop other complications. Most of us, at least in the community practice, maybe in corporate is different. We try starting 3 times a week, which the patient refuses. And if he's on twice a week, it's difficult to shift him to 3 times a week. We who are lovers of PD find it very difficult to convince patient to choose PD over HD. The vascular access issues, which is the Achilles heel of all patients, and this is why I think Mayuri also chose a topic of vascular access problems. The issues of accelerated hypertension or hypotension. In this case, we had hypertension, but in a lot of them, there'll be hypotension and loss of vascular access or hospitalization due to the same. The issue of interdialysis weight gain management and maintaining the dry weight, for which I think a lot of patients find it difficult to control, especially over the weekend. And I think one of the areas where, at least in my community practice, and which is going to be a large number of dialysis patients, especially with the National Dialysis Program, our infections rate in dialysis patients is much higher. And predominantly, the healthcare workers are not following infection control and other protocols, which is one of the reasons why the complications on dialysis are far more, not just infection. And as I mentioned, nephrologists not been able to give enough time on HD patients. So these were the 10 vexatious issues which I faced, including I could find it difficult to give time for dialysis. Next slide, please. Now, of this, I chose, next slide, please. So of all these, I chose infections in dialysis patients. Is it difficult to move the slides?
Puneet?
Hello, Puneet.
Yeah.
So I chose infections because I faced this as one of my major issues in the community. And we all know that they are the most common cause of hospitalization in incident dialysis population. In fact, in the first year of dialysis infection, they are the leading cause of death. And if you take a longer vintage also, in the prevalent population also, infections are the second most common cause of death in dialysis, next only to cardiac deaths. Next, please. Unfortunately, there is improvement in cardiovascular related hospitalization, but far less improvement in infection related hospitalization, which is a source of major concern. And in USA, they have done quite a bit of work to reduce the infection rate, and the rates have now started declining due to various measures, the top of which was the Target Zero Infections NTDS, which is the project of CDC and American Society of Nephrology, where nephrologists were transforming dialysis safety. Next slide, please. And this led to targeting zero infections, where the nephrologists were engaging, they were the team leaders, making the nurses, technicians, and other people in the dialysis, including the dialysis doctors, to reduce the infection rate. Next, please. We all know about acute infection, what they lead to. Definitely endotoxemia, septic shock is one of the most dangerous thing. Next, please. But it's the chronic recurrent low-grade inflammation which people are not able to judge as to why their patient is not responding to his hemoglobin injections, or why there is so much of malnutrition, why there are aches and pains in joints, and sometimes carpal tunnel syndrome, the beta 2 microglobin amyloidosis, and of course the dreaded MIA syndrome, malnutrition, inflammation, atherosclerosis, which is in long-term dialysis patients, especially with the catheter patients. Next, please. So as and when you treat infections in dialysis or come across it, there are two dictums you have to remember. Fever and rigors in a dialysis patient is CRBSI unless proven otherwise. And the second dictum also is important, that all fevers in dialysis are not due to CRBSI. You must have an eye to pick up the other cause of fever also. Next, please. So we all know, and I think there was some discussion on the sources of infection in dialysis patients, CRBSI being the commonest, but dialysis is a procedure, and unfortunately our advances in dialysis treatment has not occurred in a way that we can reduce some of these water-based infections which occur as a part of treatment the way we are doing dialysis right now. So the water treatment plant, or the pre-treatment plant, like carbon, sand filters, the RO system, the water tank, the distribution pipelines, all these, including the reprocessing system or the dialysis machines or the liquid bicarbonate dialysate and dialyzer reuse. So there are plenty of areas to work on and food for thought as to which is the area which is causing infection. And this is a major part which, as everybody pointed out, is not seen by the nephrologists today because they hardly go to the dialysis units. Of course, as Mayuri also pointed out, that there are other straightforward patient-centric non-dialysis causes like flu, pneumonia, skin and soft tissue injury or infection. Like in this patient, if there is a atrophic ulcer, it can get infected. In polycystic kidneys or other patients who could have urinary infection, the GI infection and so on. And not to forget that TB in our country would be one of the reasons of infection. Next, please. Of course, we have hepatitis B and C as specific to dialysis patient. Next slide, please. So since we are not going to discuss CRBSI in details, I thought at least just let me summarize so that we get the salient points of CRBSI. Predominantly 60 to 70% will be gram-positive, coagulate negative staph or staph aureus or enterococci. 20 to 30% in some centers in our country, there is much more prevalence of gram-negative also, Klebsiella, E. coli, Pseudomonas, and occasionally you could have fungal and candidal infections, especially in peripheral centers with perm cath and so on. We know the diagnostic approach when you're suspecting CRBSI. The classical symptoms of fever, vomiting, hypotension, either during as soon as you start in an hour or two or post HT over a couple of hours. We know what we do during the suspicion of CRBSI. We send paired blood cultures before we start antibiotics, one from the catheter lumen and one from the peripheral vein. If you get the same organism from both catheter and peripheral blood, it confirms CRBSI, especially if the colony count is more than 3 times higher from the catheter sample, or there is differential time to positivity. That means 2 hours earlier, you have the growth in catheter versus the peripheral vein. Next, please. In short, how do we manage it? After we've sent the culture, we start empiric antibiotics. For if you have a gram-positive suspicion, or you cover both gram-positive and gram-negative, broad spectrum. For gram-positive, use either vancomycin, cefazoline, or if you're suspecting MRSA, then daptomycin. For gram-negative, ceftazidime or cefepime or meropenem or aminoglycosides based on the local spectrum in your area. Obviously, clinically, you look for any tunnel infection is there or not. Is the patient just having fever or is he septic? And as mentioned, I think in the discussion also, whether there is a metastatic focus of infection like endocarditis, osteomyelitis, and sometimes liver and splenic abscesses or bone abscesses and so on. The duration of treatment, roughly 2 weeks for coagulous negative staph and enterococcus, longer duration for staph aureus, maybe 4 to 6 weeks, and in fungal infections, 2 to 3 weeks. Once you suspect endocarditis or bone metastasis, it would go up to 6 weeks. Do we remove the catheter or not? Immediate removal if there is a suspicion of bad septic shock or fungal infection, and some people even staph aureus. Catheter salvage procedure may be possible at times with the addition of antibiotic locks, and we know that we have vancomycin, amikacin, and taurodine antibiotic locks available, but this is not the time to discuss those. Next slide, please. However, when you have fever in a dialysis unit, you need to have a Sherlock Holmes kind of mindset. You need to audit all the fevers in dialysis unit for you to really get to the bottom of the fevers. Next, please. So fever on chills, I think it will be difficult to go to each one. Yeah, I think you can keep doing it. Fever on chills on dialysis, there are questions that should come in our mind. How many patients got fever during that shift? How much time after starting dialysis and in which shift fever was seen? How severe is the fever? Is it associated with hypotension? In which case, it's not just a endotoxin-related fever or pyrogenic reaction, then it's more of a septic situation. Whether the patient was on catheter or AV fistula or fever is happening in both the kind of patients. Is it a new or a reused dialyzer and tubing? Because the reasons might be different. Have the center or the hospital changed its policy of buying normal saline IV set heparin brands of a different brand? Was there any maintenance work done previous night? And this happens at very common on Sunday. There is maintenance on Monday because it's not adequately treated. Post-maintenance, you get fever and so on. So these are specific questions which should come in mind in anybody who's investigating fever, which is not easily discernible as to what. There are specific dialysate related questions, whether there is change in the feed water quality. This happens at least in Mumbai when monsoons come, the fever is high, or even dead of summer when the water quality is from rock bottom areas, then the fever and rigors increase. Maintenance issue related to RO water, whether the center and the chief technician is prompt in doing all the protocols for RO treatment plant maintenance, whether the tank and distribution piping systems or protocols are in place or not in that particular center. How is the bicarbonate dialysate preparation done? Many centers, it's the ward boys or moushis or ayabais who are doing the dialysate preparation. Is the machine tubing getting clogged because of bicarbonate precipitation and so on? Next, please. So the first important question is how many patients on dialysis are getting rigors? Is it just one or two patients getting rigors, or there are multiple people who are getting rigors? Most of these slides are given to me by Dr. Rajesh Kumar, my friend and colleague, and with whom we were partnering for some time. And that's for acknowledging him, because he's done a good amount of work on fever in this dialysis center. So, and I had kept him standby in case I don't reach on time, and therefore Rajesh must be listening probably to the slides. Yeah. So how many patients on dialysis get rigors is very important. If it's just one or two, most likely to be vascular access infection. Occasionally, a dialyzer reuse issue happens. For example, if this patient came in the morning, could not, it was rinsed and kept, and after about half an hour, 1 hour, whatever problems, and he could not complete his dialysis, comes again in the afternoon, and you're using the same dialyzer, which happens in many of these centers, that you have not kept the disinfectant for around 12 hours or more, which is required, or if the reuse conditions in the center, in the reuse areas, are not optimal. And of course, if you have only one patient having a patient-centric non-dialysis causes, then that's usually the reason. So any normal cause of fever, vascular access infection, and dialyzer reuse for that particular patient is generally what you need to suspect if you have just one or two patients having rigors in the entire batch of, say, 15 to 20 people on dialysis. But if you have multiple patients getting rigors, then you need to look at dialysate contamination as the primary reason why fever is happening. And then there are multiple causes of dialysate contamination, which will come to it as we progress. And of course, if your reuse machine, dialyzer reuse issues could be such that there are many reasons why a dialyzer reuse may not be optimal. Next, please. So again, I think you'll have to keep doing on. So whenever there is a dialysate contamination, there are these four areas you need to concentrate on. Why is the dialysate infected? Is it the water problem, whether it's the RO plant feed water issues? Is there stagnation in the storage tank or distribution piping or dialysis machine? Is the liquid bicarbonate preparation faulty, or is the machine proportionating system, there is precipitate and there are issues with that? Next, please. So sources of infection dialysis unit, we all know because we have studied the water treatment plant. So you have feed water, you have RO water treatment plant, you have tank water stagnation, you have water distribution piping systems, the bicarbonate dialysate preparation, and the bicarbonate precipitation, the machine tubing, which is what I mentioned in the previous slide. So these are the areas one need to look at if the infection is not due to CRBSA and not due to the patient having simple fevers, non-dialysis related. Next, please. Feed water, we know either it's groundwater or surface water. It's the surface water which has more organics and microbes rather than groundwater, which is rich more in high inorganic ions or metals, which is heavier, rather than surface water, which is comparatively lighter. Next, please. So the pre-treatment as a source is a very important area, and especially the when you look at deionizer, softener, and carbon, it's the carbon which is the one which has the heaviest growth or chance or acts as a reservoir for bacteria and endotoxin. That's because of the structure of the carbon charcoal, which is there in the filter that is made. Also, because carbon removes chlorine, and that is what it makes it little more prone to infection. Next slide, please. The material in this activated carbon cartridge, see it's almost like a delta or a gulf from where the fluid goes. If that's the main way in which the carbon charcoal is put in the filter. And if the filter has not been used for at least 5 days, or if large quantities of water have been treated, the bacterial population can increase. Next, please. And then, of course, after that, you have the RO, then the ultraviolet, the UV, then you have ultrafilter and submicron filters. Most of the times, these are not the sources, but they can become, because they can get colonized also if you don't follow the protocols of sterilization. Next, please. Now, this is the most important slide, and this is actually the paper from Canard's unit in France, and they have taken samples at every step: raw water, softener, carbon filter, and shown that as you take the water from raw water onwards, the level of organisms and endotoxins keep increasing, maximum from carbon filter onwards. And then you have the RO plant, which takes care of all that till can I be able to show? Yeah. Till we reach the recirculating loop, from where, as the fluid recirculates from here, it again catches the endotoxins, predominantly maybe from the biofilm, which is there in the recirculation loops, the pipes and connections and so on. And again, it's the help of ultrafilter that you get the ultra pure water. So every area, there is a possibility of infection. And it's very important, as you notice, that this RO plant has to be in excellent shape. The recirculating areas have to be good. There should not be biofilm, and you should have good ultrafilter, which is why when you talk of HDF, you have a double RO and a double ultrafilter to give you ultra pure water. And that's the idea of showing this graph. Next, please. Yeah, so the carbon filter, and that's the important area. So any ineffective RO water treatment will increase the risk of dialysis contamination and infection. Next, please. So once the RO is sorted, it's the water stagnation that is the principal area from where infection can come up, either from the storage tank, poor designing of distribution piping, multiple bends and dead ends. The pipe which eventually connects to the dialysis machine from the distribution network, even that plastic pipe also needs to be seen, and the dialysis machine. Next, please. Yeah. So the water storage tank and the distribution piping has to have certain specific design material, etc., and a specific method of disinfection. Next, please. Yeah, so the water storage, it should be designed in such a manner to prevent stagnation and control of bacterial growth, and it should be easy to disinfect it. And the best way to do it is, one, not to have a water storage tank. That means directly send it to the machines. But if you have to have, which is mandate, I think, which is there in most of the centers, then it should be conical or bowl-shaped base. There should be a tight-fitting lid with air filter. And post-water tank, you have to have ultrafilter or equivalent. You should frequently drain it and adequately disinfect. Like this is a bad water tank. Next, please. So large surface area and flat base, as seen, this can act as a reservoir for water bacteria, and hence a properly designed tank can minimize this risk. Next, please. Distribution piping again is important. Normally you have all the centers with either PVC or stainless steel, but there are many types of stainless steel. You should insist on 316L. These are the two most used materials in hemodialysis unit, and you should see that there are no rough edges at joints, elbow, union, and T where bacteria can proliferate. If the purified water, chemical water flow is... So many times the disinfection can also damage it if the material used is not up to the standard. Next, please. Pipe materials and types of chemical disinfectant use can influence bacterial colonization and biofilm formation. And biofilm formation, let me tell you, is one of the worst things that happens, and it happens quite commonly. Next, please. The water distribution, I think this you can, is in series. Yeah. So when you have a water distribution loop, an oversized diameter and length can decrease the water flow speed and increase the stagnation. And it's the stagnation which helps in biofilm formation. It increases the bacterial growth and biofilm formation. Rough joints, dead ends, we already told are areas. And if you have branches which are unused, then those areas will act as a bacterial reservoir. Next, please. So even if you have an effective RO water treatment and you do everything possible there, But if you have a poorly designed water distribution system, then it can increase the risk of dialysate contamination. Next, please. How do you disinfect the loop? And this disinfection loop is one of the most important areas which I think a dialysis technician is aware of, but sometimes they do not follow protocols. So 1% sodium hypochlorite or 2% peracetic acid is circulated in the loop for an hour and then it's drained out. And following that, you rinse the loop with RO water thoroughly and check for any residual chemical is there or not. Some people, especially I know in Mumbai, they use ozone or hot water and steam to disinfect it. Next, this prevents probably chemical use. I think biofilm is something which is one of the reasons why infections give so much trouble in the water treatment plant. To prevent it, it's difficult. You should have ultra pure water. There should be no dead ends. We talked of all this. Disinfecting or descaling is quite difficult. Even if you use strong oxidizing agents still. And at times you just need to change the distribution system if it's chronic and giving a lot of problem. Next, please. So multiple patients having rigors. We saw the above two reasons. And now we move on to the third reason where you could have improper bicarbonate mixing as the reason for multiple patients having rigors. Next, please. Now, this slide actually tells you that how liquid bicarbonate actually is used because it's cheaper. Instead of using bibag or the powder with the online bicarbonate concentration, most of the centers, at least in non-corporate hospitals, definitely use the liquid bicarbonate. There is a potential for bacteriological and endotoxin development, and see within 48 to 72 hours, the level of bacteria goes up tremendously, including even the endotoxin. Next, please. And this slide actually tells you that even Pseudomonas in the dialysate level went up so much if you delay the using of dialysate. Next, please. So, next, please. So, liquid bicarbonate predominantly just for reducing the costing. Main objective of using that is, but if you do not, or if you compromise on the quality and patient, if you do not do it properly, it could lead to infections. Next, please. So the best way to use it is to make it fresh just before the dialysis is starting. You should use it within 6 hours after opening the container, which sometimes in some centers, people who are on night duty prepare it and go in the morning when the first shift starts, they use it, which is, of course, one of the recipe for infections in the unit. Next, please. Now, these are all the experience we faced in the smaller community dialysis centers. So online production of dialysate with bicarbonate powder, which is now done in many centers, it is a good way to prevent bicarbonate getting infected, dialysate getting infected. Next, please. The bicarbonate mixer which is used should be cleaned, acid cleaned with 1:34 dilution of 5% acetic acid every week. Next, please. Moving on from dialysate preparation, we go on to the dialyzer reprocessing. If that is ineffective, again, it will lead to fever and rigors. Next, please. The dialyzer reuse in certain patients on, say, Pradhan Mantri Yojana, or we have Mahatma Jyotibai Phule and many others where there is a PPP program. Most centers use dialyzers at least 10 times, dialyzer and tubing, and each subsequent dialyzer use is associated with 7% increase in the risk of acquiring a bloodstream infection. So dialyzer reprocessing is an area which needs to be worked upon. Next, please. And the reasons why reprocessing leads to problem is sometimes the water is not of AMI standard. There is improper dilution of the concentration used. Dialyzer not disinfected in the timely manner. As soon as the dialysis is over, the organic material is, if not cleaned adequately and properly, if there is a little bit of clotting on the sides, the dialyzer header and O-rings in the header caps, these are areas which can get contaminated and they need to be properly disinfected. And that's why reprocessing of dialyzer is a problem. And hence a lot of good centers now do not reuse dialyzers and tubings. Next, please. The dialyzer reprocessing as done in most centers is either automated or manual. Most centers nowadays do automated rather than manual, and automated is supposedly better because you are actually relying on the machine. No, I think you can go back to the previous slide. Yeah, next one. Unfortunately, even the machine can have hydraulic problem. It can malfunction, and sometimes there is a chemical dilution error based on the concentration you have used. Manual, it's prone to human error. It's never reproducible and consistent, and there is always breach of SOP. So we can rely on machines most of the time, but somebody needs to be vigilant, especially the chief technician. Next, please. The peracetic acid used, or the Renalin, Renaclean, Hemoclean, whatever is used in your center, it has its own issues. If it is exposed to temperature greater than 27 degree or exposed to sunlight, or the organic matter is not clean, then when it mixes with blood and protein, it can lead to it may not be effective. And sometimes the peracetic acid solution, it has a very short half-life, and many times if it's used after a longer period, it may be ineffective. And improper dilution can lead to bacterial growth. Next, please. Very rarely it's due to saline or consumables or heparin. Earlier people used to have multi-dose vials, and that was one of the reasons for it. I think we are running short of time, so I'll skip some of the slides. Next, please. Yeah, we can leave the case studies. This was basically, you can go to the next couple of slides. This basically was a problem with, and this is of course typically Indian. Some of the companies who manufacture IV fluids or IV set may not be up to the standards. And there was in a unit so many cases of Rigers, whether they had catheter or fistula, whether they were morning shift or afternoon shift or evening shift. The moment they changed the IV fluid, saline, and IV set brand, everything disappeared, and there was no pyrogenic reaction. Unfortunately, next please. In one shift, somebody brought the same old IV set, and again there were Rigers in that set, just trying to prove that it's the batch which was faulty. Next please. So these are just rare cases, but the point is that, next please, that one has to keep and think out of the box sometimes. Multiple patients having Rigers in a day, we know how to handle. You can assess for signs and sources of infection, obtain blood cultures, start antibiotics, give antipyretics, and then discontinue dialysis without returning blood if pyrogen or endotoxin is suspected. We'll send samples for dialysate to culture. There are certain specific points about sending for culture, which we'll come to in a minute. Next, please. So this is what we call as root cause analysis of fever in the dialysis unit, which is related to these causes. Next, please. The organisms which we see in PERM-CAT infection or CRBSI are different from the organisms which are responsible for Rigers during dialysis.
Dr. Umesh?
Hello.
Yeah, I can't. I think we lost him.
Loss of connection.
We seem to have lost
Yeah,
him.
lost. The link is gone.
While he's trying to reconnect or whatever, I must say that this shows that actually, if you have spent a lifetime in dialysis units, this kind of root cause analysis, as well as see, when you look at fevers in dialysis units, you will not find in the books usually water treatment and all being assessed the way Umesh has done it. But I think it speaks volumes for the amount of experience and all that. And I think 20 to 30% of fevers, especially if you have multiple patients which develop fever during dialysis, look at water treatment systems, distribution, and as he has highlighted. And I think these are not uncommon causes of fever, especially when more than 2, 3, or multiple patients in the same shift. This would be one of the reasons, in addition to CRBSI and others, which are obviously more common. I'm not saying that they are uncommon, they're more common. But then these are causes which are not usually picked up in the books, and only someone who's done an audit of the systems or looked at these problems would find these causes and how these need to be looked at. And I think most nephrologists probably wouldn't have gone and seen the RO unit. I don't know how many students have gone and looked at the RO unit in their hospitals.
Center. Yeah.
So,
One other point I'd like to make. In fact, I wanted to ask Umesh about that also. Most units do not have centralized production of dialysate. We have only a centralized production of the concentrate, and the dialysate, final dialysate, which goes to each patient, is prepared by his own machine,
Yeah.
mixing it with water.
Yeah.
But in certain countries like Japan, there has been for a long time centralized production of dialysate, which is then circulated to each patient. And in the PGI, they required replacement of their water purification system, which had become very old. And this is the kind of system that has now been installed by Fresenius.
Yeah.
So there is centralized production of dialysate. So I think residents should be aware of this possibility also.
But
Yeah,
very
even
well
Dr.
said,
Dr. Sakhuja, we also had this when we were about to finish our DM. You remember that centralized system of we had these monitors which were installed. Just this was something. Maybe you had left. I don't know. I think you were there.
I was there.
Yeah. This was, I think you were there, and we had that, and then they again moved back to when they got new machines, probably. For some period of time, there was a monitors only, and then centralized dialysate used to be circulated to these monitors and to the patients.
But the difference was that at that time, we really didn't have sophisticated, modern water purification system.
I
it was very primitive at that time.
Professor Sakhuja, if I recollect, in 90s, we used to have water straight from the tap. The machine used to be connected like that. Then gradually the deionizers, every hospital started a deionizers. There was a cation anion exchange resin. And they started functioning.
Deionizers. We didn't have an RO system. I think deionizers and water softeners.
Water softener, and these were there.
Deionizers.
And as Umesh is rightly mentioning, such episodes and epidemics of fever occur in every dialysis unit, sometime or the other.
Yes.
And we had, once again, 3 years back, a bad system, a bad epidemic of fever. Practically everybody was having rigors. And as he's rightly putting that, you keep doing searching where the point has come. You take water from all the machines, you go to the RO plant, but eventually you find all these tubes and network of pipes which are there. One
distribution system
infected, the biofilm and all. And one has to keep in mind all that. And as one has to remember that, as Umesh was mentioning about the CRBSI, in India, many of the centers are finding that gram-negative infection is commoner than gram-positive infection, which is a common thing in the Western world. But in India, I don't know the reason, but SGPGI was analyzing the reason once, and again we felt that maybe our environment, our hospitals, the institutions are flooded with gram-negative organism. Some of the hospitals you'll find always will grow Klebsiella, some will grow always Pseudomonas, wherever you touch it. So these organisms are rampant in our institutions, and possibly they are responsible for whatever CRBSIs we are having. Uh, I think that's again very informative message he gave, that dialyzer use, that each dialysis reuse possibly gives a risk of 7% of infection or CRBSI which can occur. Are you there, Dr. Umesh?
Yes, I am there, but I thought there is a system in place in core that if you cross 8 p.m., it automatically gets disconnected.
No.
Unfortunately, it was
No,
my Wi-Fi which
no,
went
no.
off.
We
But
don't do that at all.
I'll just conclude. I think we'll finish off. We'll
Yeah.
just take the concluding
No,
slide.
we just started discussion because you were
We
not
thought you
available.
were-
So we were complimenting you for this description of water system, because this is not usually what one would hear in a usual lecture. Someone like you, who with that kind of experience in this dialysis for so many years, is the one who would look at it in that incisive manner. Thanks for that. Thanks for
Yeah, I
that.
think in the next 5 minutes, I'll try and close it. Just a few
Sure.
salient points. If you can just run through the slides. Next one, please. So, yeah, I think so. So the rigors could be because of, I think, previous slide, because of viable organism, and which is what you grow in culture. But there are microbial products, which is endotoxins, which has a different methods of testing. Next, please. And I thought people should be aware that biofilm we have done. Next, please. People should be aware that there are special methods to detect bacterial contamination, and the bacteria are to be grown in cultures which are slow growing. Next, please. I will show the problems which are there. This we know. You measure endotoxins by LAL or Limulus amoebocyte lysate, and some of the endotoxins require a special test called cytokine. Next, please.
Inducing.
Yeah. Cytokine induction assay, which are for other components of bacterial cell wall, the peptidoglycans and so on. So LAL assay we know is for LPS and lipid endotoxins, and cytokine induction assay is for other components of bacterial cell wall. Next, please. The point that I was trying to make is that when you try and grow organisms from dialysis water, the growth will take a long time. You need to have prolonged incubation time of almost 7 days before you grow things. And for the fungi and yeast, you need the special medium, the malt extract agar, which will help in growing it. So I think this is one area you can't send it to a normal culture lab to do it. Next, please. If you need to grow the organism in a bicarbonate liquid sample, then these samples also have to be salt rich. And that only will grow the colony counts and so on. Next, please. In fact, you need to add 4% soda bicarb to either of these mediums. Sampling sites is important. Where do you sample the fluid from? The dialysis water, you need to pick it up from the outlet of the RO equipment, and the dialysate fluid from the inlet line of dialyzer. Next, please. I think, and we know what we have to aim to achieve. The microbial contamination level, the colony forming unit should be less than 100 in the regular dialysis, and endotoxin should be less than 0.25. But if you are into HDF or high flux dialysis, then you will need ultra pure water, where the microbial contamination is less than 0.1 and endotoxin level is less than 0.03. Next, please. And which is why we have double ROs and double ultra filters. So major challenges is there. Next, please. I think now we'll just go on to the concluding slides. Next, please. Next, please. This is an area which is very close to our heart, and therefore there are many slides. So I think we just move on to the last concluding slide. We're already crossing the limits. So this RO maintenance is an important thing which a senior person, senior technician should be doing. No, I think you just go to the conclusion. As a nephrologist, you must keep a watch on these areas when you go on to the unit. Although Dr. Vinay Sakhuja rightly mentioned that nobody goes to the unit. Previous slide. Previous slide. Previous slide. Previous. There is a patient area. Yeah, that was the slide. Okay, anyway. Let's move on to the conclusion. We're already too late. This not handling the slide yourself is an issue, technical. Last 2-3 slides, please. Next. Maybe Dr. Varma, these slides can be shared if somebody wants.
Okay.
Yeah. So in conclusion, we see a lot of issues of dialysis, but since I thought I'll take only the infection part, if you have multiple patients getting Rigers in dialysis unit, it is due to dialysate contamination, occasionally due to dialyzer reprocessing, consumable problems. If your RO water treatment plant is not properly protocolized, the distribution piping system is not sterilized, there is no maintenance of RO plant logs, etc., then these problems occur. Online production of dialysate with bicarbonate powder is the best way to use liquid bicarbonate, but very few centers are doing it. Next, please. You should have a dialysis unit staff, senior person who is well versed. You may have to invest in a good dialysis technician because as nephrologists, we hardly go. The senior technician, senior nurse, and a dialysis doctor are the main people who run the dialysis unit. And they should be made to follow protocols, maintain water and dialysate quality, always use ultrafilter, see that the ultrafilter is not too late, whatever, every 3 months, whatever, before the diasafe filters have to be changed. Use fresh bicarbonate solution, and the reuse area needs to be thought of. Next, please. And thank you so much. We all together should work on something like what the Americans did to try and get zero infection in dialysis. And that is one area which I think with the national dialysis program going on, more and more centers are actually facing this problem of infection in dialysis. Thank you so much for giving me this opportunity, Dr. Varma, Vijay and Sakhuja. I have always been a fan of this masterclass.
Thank you so much, Umesh. It was wonderful. I must tell you that you have to be very passionate about the dialysis to know all this. And what you have highlighted, that every area of a dialysis center, whether it's a RO plant, whether it's a carbon filter, whether it's a machine, whether it's a bicarbonate processing, whether it's a reuse, every area has got its own importance. And as you rightly put, a passionate person, a very senior technician are the people who have got aptitude and who are really going into it. They are required. I think
so my suggestion is there were a few slides which I have not covered because of lack of time. And these are the practical tips which people can give to their technicians. And maybe these slides, if anybody is interested, these will cover. They are very self-explanatory. So if you would want to share it, I'm quite okay.
We will involve you in some other forum so that you get the opportunity to talk on them also. Yeah. So, no, that's very nice. I think both
of you. This was the last one, and you will excuse me.
Yeah, both of you did excellent job. And whether the common problem of vascular excess, how it can be dangerous, that the fistula, the steel phenomena, what was occurring, and a subtle peripheral vascular disease along with that can add fire to the fuel. So I think overall, excellent. And I'll request Professor Vijay Kher and Professor Sakhuja to give their comments before we conclude.
Yeah, no, I was already saying, maybe I wasn't sure whether Umesh heard it or not, but I was saying that these kind of comments and the talk that Umesh gave was exceptionally good and very useful, and you learn a lot actually. This is something that most people don't talk about. Water system is talked about, but then practical issues which come with the water systems are not usually talked about. And someone as passionate as you in dialysis, I think you given it really an audit that you people would have done and then picked up the commonest kind of issues which arise in this, and this is not being talked about. So I think I must congratulate you, Umesh, for bringing it out, because this is a neglected area in the dialysis unit. And as you said, more and more dialysis units are going to be opened up. There is a national dialysis program. At the moment, we are looking at quantity, but we're not looking at quality. So we might get into more and more problems of this sort. And if you don't know about this, then you don't. And I can tell you that when I went to Sanjay Gandhi Postgraduate Institute for the first time, the institute was being built, and I was being asked, where should you put the pipes? What kind of pipes? I had no idea. I had gone to US. I said, but you usually don't go, and as I was saying, you don't go to the water treatment systems and don't study them. I had not, and that was the first opportunity for me to sort of open a book and try to see what do I tell these engineers as to how it is. And I think that has been a great learning experience. And I'm sure that the same has happened to you as well, as you were building your units and all that. And then over the years, all of us have learned kind of things. And I must again compliment both you as well as Mayuri for bringing out this patient with vascular excess, which is again neglected area for nephrologists. And I think it was very nice for General Verma to pick up a dialysis topic. And I think I would now hand it over to Dr. Sakhuja for his wise words, as always. Dr. Sakhuja.
I think, Vijay, you've summed it up very well. I don't think I need to add much to that. I don't think I can really add much. But once again, I'd like to thank Dr. Umesh for masterly presentation. And the students would have learned a lot from that. And thank you once again for including me in this discussion as well. Thanks a lot.
Thank you. So I think with this, probably maybe we can close. Thank you. Anything else? Umesh, you want to say something?
No, thanks.
Thank you.
I'm very happy that I was a part of this.
Mayuri, you have anything to add or?
No, sir. Thank you very much, sir. Thank you.
No, it has been a huge learning experience, I must say. And I think, thank you both, Umesh, as well as, and I, on behalf of General Verma, maybe General Verma, we can close now.
Yeah, definitely, sir.
I think we could. We would like to thank both of them, as well as Naman. Naman did a very good presentation, and I must congratulate him as well for an excellent presentation. And we must thank Steadfast, Puneet, and his team for providing us the technical kind of support, as well as arranging these classes and doing the groundwork for these classes. So on behalf of Kern and on behalf of Dr. Sakhuja and General Verma, I would like to say thank you and goodbye until we come in another 15 days with another class. Thank you very much. Thank you. Good night. Bye-bye.
Thank you.
Thank you very much, faculty, for the practical pearls of wisdom. And with your permission, Dr. Khanna, we'll share these slides with the students. Thank you again. Good night.